Hi, Dr. Geeta. Hey, आप muted हो? You're muted. You're muted.
तुमने मेरे को म्यूट कर रखा है. Hi अनुज.
Hi, Dr. Geeta.
अरे तुमने तो सारे बाल सफेद कर दिए.
I am getting ready.
To look your part, huh?
Yeah, exactly. At least this should not be, a disqualifying factor.
Hi, Abrari. So see, Abrari can't hear me.
I think he's
connecting still. Yeah,
he's still connecting to audio.
Yeah.
So he might have to go back and rejoin. This is what I feel. This is how the system works. You go out, you replug and you reboot and come back in.
Reboot and come back again. Yeah.
Dr. Geeta, pun intended.
I hope nobody is reading between the lines. Abrari, are you? Can't hear you.
Dr. Geeta, where do we check for the questions? And where exactly? In the chat box?
So, So the chat box is where the participants will be putting in their questions.
Fine.
And Dr. Shubham will be playing the PowerPoint for the quiz.
Great. Fine.
Yeah.
Let me just, can you message to Dr. Abrari that he should, exit and reconnect for the audio to be, I think that might help. Because I'm not sure if he'll get a chat. Let me try messaging it to him.
I've messaged him on his WhatsApp. Let's see.
Yeah.
He needs to connect to his internet audio.
He's speaking something, but we can't hear
it. It shows still connecting to audio.
Yeah.
Yeah,
Okay,
now there is some
connected.
movement. Yeah. Abrari, can you just unmute yourself?
Unmute, yes.
Unmute yourself, please.
Okay, let me ask to unmute and then probably he can button.
Now can you hear me?
Yes.
Yes.
Welcome, Abrari.
Hello, sir.
All right.
So been a long time, no? So I thought this was a good excuse to bring you back to the fold.
Back to the fold, yes?
Yes.
Hi,
So
sir.
how are you doing?
Oh, well enough, I must say. Yeah.
Is it tough? Is it easier? Is it better? How does it work?
I must say it's not tough. And I will not say it's much better. There are things which are different from back in India, yes, but much different, but yeah. Just tell me, how do I share my presentation? How do I share my...
So you would, on the bar below, you would see an option of sharing your screen.
Yeah.
Yes. So just click on that and you will be able to go to your home screen where you will see your PPT. You can put your PPT on your desktop, PPT or Keynote, whichever you have.
Yeah. But it's blanked out, that share screen thing. Am I already sharing it?
No, you're not sharing it. Just move your cursor around. Either it will come on the bar below or at the top, a bar would come where you would have controls of your audio and your video.
No, I have that thing, share screen over here.
Yes,
Yeah.
just press the
Click.
share screen.
I'm doing it. No, nothing's happening.
Okay. So what we can do is, can you mail that presentation to me? I can run it for you if that is okay. Or we can, or you can mail it to Dr. Anuj. Dr. Anuj can run it for you.
Mm-hmm. But why is it blacked out? Just, can you give me a second?
Yeah. Please take your time.
Sorry to keep everybody waiting. Just wait, I'm mailing it.
Yeah. Just mail it to Dr. Anuj.
Yeah.
So Dr. Anuj, you can share screen. You are also co-host. So you will be able to share screen, and whenever Dr. Abrari says, you can just move it to the next slide.
Fine, I'll try.
Yeah.
Is it a big file?
No, it's not too big.
Oh, then it's fine. Then you should be able to do it.
7-8 MB, I think. Anuj, your
Hi,
email.
sir.
Yeah.
Yeah. So you can email it at ASMA.
No, Dr. Anuj, just message it to him privately.
Okay. Sir, I'll put it on a WhatsApp.
Yeah.
Yeah, or on the chat box of Zoom, whichever is easier.
Sir, I put in a WhatsApp to you.
Mm-hmm, yeah. So that's something, asmakurana@gmail.com. Is that
Correct?
Is there a dot in between? No.
No, there isn't.
Okay.
So in the meantime, please, you can email it to Shubham as well. So whosoever gets it earlier can start the session.
I am putting you a message on the chat box. The Zoom chat box. Can you see it? I just message to you if you can.
Dr. Shubham Garg at Gmail है ना तुम्हारा तो?
Dr. Shubham Garg@gmail.com.
Yeah.
That should be it.
So in the meantime, I think, we can start with the quiz.
Yeah. That
Yeah.
Okay. So just let me. All right. So it's 8:35 on a Wednesday evening, and we are back with Cancer Academy, and I welcome all of you on today's tutorial in Cancer Academy. Today we are truly going international for the first time, and we have with us a truly international speaker, and we'll be, you know, I wish Zoom was simpler, and every time we find something to give a feedback to Zoom people that we can still make it simpler. But yes, this is technical challenges that we face every time, but we'll cover them. But what we started last week talking about cancer metastasis of unknown primary, we are moving a step forward from the workup to the actual pathological picture, which plays so much important role in deciding the tissue of origin, and how we can use immunohistochemistry and further cytogenetical analysis to find out the exact tissue of origin, which defines not just the treatment but also the prognosis of such patients. And we have with us a very dear speaker, a good friend of I'm actually meeting Dr. Abrari for the first time, but Dr. Geeta, Dr. Anuj have worked with him, and I'm sure Dr. Geeta will introduce him. In the meanwhile, before we go there, I'll introduce Dr. Anuj Khurana. Dr. Anuj Khurana is a senior consultant histopathologist at the Max Institute of Cancer Care, Saket. He's a very experienced pathologist, and the color of his hair reflects all his experience and wisdom. And it is really moderate this session for us. We have not had a quiz for the past 3 or 4 weeks, but Dr. Anuj was very kind to us to create a quiz for this, and I will play the quiz. And the rules of the quiz remain the same, that we request you to send your answers on a WhatsApp. I'll just share the screen. So, okay. So the quiz goes like this, that this is the number on which you have to submit your answer: 9953621242. Dr. Geeta will just put it in the chat box. 9953621242. You have to save it in your phone so that it appears in your WhatsApp group. And there are 5 multiple choice questions, each with 4 options. And we request you to send one consolidated message at the end of the 5 questions, writing your name, your institute name, and the correct sequence of answers, be it 1, 2, 3, 4, 1 or 4, 3, 2, 1, whichever is the correct sequence at the end of the 5 questions, which Dr. Anuj will read from now on. Dr. Anuj, the first question.
Yeah. So before I start, I'll tell you, as the color of my hair can be misleading, even IHC can be quite misleading. So let's start. Shubham, the first question.
Yeah.
So we are talking about carcinomas. So the first question is about a co-expression of a CK7 and a CK20 carcinomas. This can be observed in the following settings, except stomach, pancreas, ovarian mucinous tumors, or the prostate. So we can get the co-expression in all of them, except which one? That's the first question. The second question is on CDX2. That's an immunostain, which can be observed in which of the following subgroups? The colorectal carcinomas, carcinomas of the pancreas and the biliary tract, stomach, or in fact, all of the above. Okay. So the third question is, which of the following immunostains strongly supports a colonic origin? The choices are a CK7, a CK20, a CDX2, or a SAT-B2. Okay. The next question is question number 4 on PAX8. PAX8 is a marker which is positive in nodal metastasis of the enlisted carcinomas except kidney, thyroid, ovary, and breast. Which of the following doesn't express PAX8? The last question. So this is a clinical scenario where a needle biopsy of a para-aortic lymph node is performed on a large mass which is inoperable. On IHC, as we're dealing with carcinomas, this tumor is positive for cytokeratin, inhibin, and calretinin. However, it is negative for GATA3 and PAX8. This mass is encasing kidney and ureter at the same time. What would be the most likely diagnosis? A hepatocellular carcinoma, a renal cell carcinoma, adrenocortical carcinoma, or a carcinoma. I have posted all these questions. These are not challenging, but these are those ones which we actually put in our day-to-day practice. So it's a panel. That's it.
Thank you. Yeah, thank you, Dr. Anuj. And I must say that these are really those questions which we come across day-to-day life. And the last one is actually a very interesting one, because this is how the clinical case scenarios actually come in the exam, and this is what we as oncologists face every day. Okay, with that, that is the end of our quiz, and you can send your answers in the following format: name, institute name, and the correct sequence of answers on this number 9953621242. And with that, now I invite Dr. Geeta to please introduce Dr. Abrari. Dr. Geeta, please.
A very good evening to everybody, and I think it is still afternoon for Dr. Abrari. Dr. Andleeb Abrari is a histopathologist, and I think our journey goes back to a very long time. We started off at Rajiv Gandhi, and then Dr. Abrari moved to Max, and then we moved to Max, and then we had an association there as well. And he's a brilliant histopathologist, and I think one of the biggest losses of MICC in that sense was losing Abrari to the UK. So, so that is where he is at the moment. And I'm sure he's doing as good a job. And he's a great guy, very approachable. And that's what oncologists like their pathologists to be. We used to be always on the phone, and he would say that we were rather at his neck most of the time to ask, to get those kind of answers, which are not easy. I think a pathologist's job is very, very, very tough. And, a pathologist who's an oncopathologist is even worse, because I'm sure in the melee of the usual kind of pathology, oncopathology is just mind-boggling. And I think the onus is on them in a way to decide how we're going to treat patients in the future. So they really have to dig deep and come up with some really, really tough answers on which will hinge the outcome of a patient suffering from cancer. So today, I'm sure Dr. Abrari is, one thing which I will never forget about Abrari was, and we were all surprised, because Dr. Abrari otherwise is a very quiet and a reserved person. And, you really have to scratch the surface several times over to discover anything at all about him. He is a great exponent of the English language. His English is just so impeccable that I can't even begin to tell you, because when I realized this, I said, oh God, so this was that pearl in that oyster we'd been missing completely. He's a brilliant writer, and he's in the right place now, because I'm sure his English would be more valued in the place that he is than it was when he was here. So that's a little bit of a snippet about Dr. Abrari, and I'm sure he's going to regale you with his talk today. So over to you, Abrari.
Thank you. I can see that button unblanked now for some reason. Can I try it once?
Yes,
otherwise,
please. Yeah, sure, sir. Sure. Just do it.
Let me see if I can do it.
Excellent.
Perfect.
You got it.
I think I did it, yeah. From the start, is it? Right, so can we...
You can go full screen.
No, are you looking at it full screen now?
No, we're seeing your slide alongside.
Just the slide.
Yeah.
I do it.
So you can go full screen.
So just
Yeah,
go to the slideshow upstairs on the top bar, top horizontal bar.
Use slideshow.
Yes.
Okay.
Oh, your screen is frozen. Oh, yes, yes.
Yeah.
Now we can see it. Perfect. Perfect.
Right.
Okay. Great.
So we are all there now.
Yes. Yes.
Right. And let me see if there's the first slide, which should come on. And how do we move the slides on the slideshow?
So on the lower left-hand corner, you'll see a couple of arrows.
Yeah, all right.
Yeah, this one. Yes.
All right. So thank you for guiding me through that. Yeah. So as far as I know, there's been an overlap of topics between the last lecture and mine. It was also on cups, isn't it?
Yes, yes, it was. It was.
So I will not take much time on what cup is, except where I have to touch about what I'm dealing with at the moment. So cup is an orphan cancer in which the routine laboratory tests have failed to reveal a putative primary or putative tissue of origin. And this constitutes about 2 to 5% of all cancers, and it's 6 to 8 most common cancer and 3rd to 4th most common cause of cancer-related deaths. The presentation of cups is heterogeneous, and 42% more or less are present. They present as lymph node mets, 33% as metastasis to the liver, 26% as mets to the lung, and 22% to the bones. About 9 to 11% are either peritoneal mets or detected on imaging for other conditions. There have been 2 hypotheses proposed for cup. One which says, very tongue-in-cheek, that this is without a premalignant lesion or without an intermediate pathway involving a primary. And it says that this originates from the stem cells, which have somehow become entangled where they were not supposed to be. Now that's very fortuitous if it is ever going to be proven to be right. And then the other hypothesis which says that the dominant primary is there somewhere, which is beyond being detected. And the genetic abnormalities in the floating tumor cell population from the dominant primary makes it metastatistically advantaged and thus giving rise to metastatic disease. Now that's wishful thinking unless it's proven to be something on the gene-protein relationships in the future. No pivotal relationship has been confirmed yet for the development and survival of cups. Now this is the be-all and end-all of practice over here, the classification of cups according to the NICE guidelines. So they say that a malignancy of undetermined primary tumor before having undertaken the investigations which are documented to be held in all cases of cup, it is termed as malignancy of undefined primary origin. Then it is provisional cup after that, when there is a metastatic epithelial or neuroendocrine cancer with only the preliminary investigations having been done. Then cup, as we recognize it, is the confirmed cup where the final histology shows metastatic epithelial or neuroendocrine cancer without any primary site when all possible specialized assessment has been completed. So these are the 3 stratifications for cup in the NICE guidelines. And the stratification is to ensure timely referral of cups to the cup MDT, which is required to be present in all centers treating cancers. and some explanation regarding why cups might be so difficult to have primaries which are detectable. So the primary tumor size there is hard to detect because of being small, one school of thought says. Then there is something which is to be said about the slower growth in the primary site, which is still undetectable, and it has given rise to a subclone which has metastatic advantage. Then immune system of the body has done away with the cancer. And surgery, I mean, that's very far-fetched, but surgery for something else has possibly removed primary, which had time to shed cells which could eventually form cups in a patient who has had surgery. But that's all conjecture, to say the least. I've just put in that table for those who might be really willing to attempt a short note. I don't think that's logical to be repeated over here. The differences are self-evident, to say the least, between metastatic cancer and cups. And it's just to summarize it that I've included that table over here. The question which arises when dealing with cups is, why do we need to characterize cups? Is it the itch to cut and dry everything so that, you know, the final documentation is beyond any reproach? But it goes beyond it. That first of all, when you are faced with a cup, you have to be sure that it is indeed a carcinoma. And if you are sure that it is a carcinoma, then coming to the type, subtype, and site if possible. Also, within cups, there are categories of cups which are sensitive to specific treatment, namely the prominent ones amongst them are breast, ovary, prostate, and thyroid, where targeted therapy is available, pulmonary or colorectal, for instance. So when we say that we have to be sure of carcinomas, it's speaking with personal experience over here. Now, this is a biopsy of one of our cases from about 10 years back, in which there was a widely disseminated cancer, and it was being investigated as for cups. And we had this endoscopic biopsy, which showed these highly atypical angry-looking cells within the gastric mucosa. And if one is in a kind of zone at that time, and if one sees such cells, and if one has got 3 phone calls in the past half an hour to accelerate the sign out of that biopsy, one would be very prone to just call it a signet-ring cell cancer and be done with it. Sometimes even without attempting the basic immunomarkers for this biopsy. It was well that the immunos were done here. Now, this was negative for all the initial markers thrown at it. And then it was a moment to step back and take a deep breath and see what was happening, because a cancer which is negative for all this, and then you have done everything for other lineages and it's negative for everything. What is it positive for them? So it's positive for factor VIII related antigen. Now, this patient has had a biopsy of the stomach, which shows these angry-looking cells, and which are only bizarre endothelial reaction mimicking epithelial malignancy. It would have been disastrous had we signed it out as signet-ring cell carcinoma. This patient had a different cancer which was widely disseminated. Now, that's another issue, but the gastric biopsy did not have cancer. So we have to be sure that we are dealing with cancer indeed. The next 2 biopsies, again, our own cases, again, widely disseminated malignancy, both biopsies of the GEJ case 1 and case 2 have nothing much to say by way of differences in how the cells look. They all look similar. So what's the diagnosis over here? Again, the first one is positive for melanoma markers, HMB45, S100, and Melan A, and is a metastatic melanoma, while case 2 is positive for markers which typify GIST, and this is actually a round cell epithelioid GIST, which in all the world of immunos, not standing, looks exactly like any other round cell undifferentiated tumor. So we have to be aware that we are indeed dealing with a carcinoma and not be rushed into making a diagnosis of carcinoma based on appearances which can be false many a times. So I'm not going into what goes into the diagnostic phases for CUP. I think they would have been covered in detail in the last lecture, but the diagnostic thrust is mainly guided by patient symptoms, which denote which sites are to be addressed primarily, although the approach should be broad-based most of the times in cases of CUP. So having confirmed CUP by the preceding investigations, the relevance of having done that much effort is that a specific primary site is unlikely to be revealed in less than 10% cases if everything has been done according to standardized guidelines. Also, about 15 to 20% of CUPs will be found, which would be the ones which respond relatively to established therapies. A large proportion of CUPs would again remain within the domain of being given empiric broad spectrum chemo then. Immunohistochemistry, now we are on our turf. Broadest utility in CUPs is to identify subsets of CUPs which are sensitive to specific treatment. And of those, the preliminary 4 sites, breast, ovary, prostate, and thyroid, are the ones which yield to specific treatment and have better outcomes overall compared to CUPs at large. Also, one should strive to confirm whether it's pulmonary or colorectal, again, because the availability of targeted therapies should guide the zeal at which we are proceeding to do the immunos. Diagnostic guidance is approximately 90% available when it has been done with some degree of restraint in undifferentiated malignant tumors, but it's an expensive algorithm-based morphology, and much depends on experience and not missing out on what should have been done and what has not been done by way of immunos. The problem with attempting to do immunos on a putative biopsy from CUPs is that the pathologist is torn between these contradictory demands. That's of small specimen size, ever proliferating tumor-specific antibodies, which when they come, promise the world, and then they diminish in importance. And then the requirement at the present time of complementary molecular analysis. So you might be doing 25 immunos, spending all the tissue, only to be let known by the oncologist 7 days hence, if you're lucky, that now tissue is required for molecular analysis, and then you dig out the block and there's nothing left in it. So that's where the balancing act should be called upon always. Having said all that, it's always wishful thinking that we will be successful in 100% of cases. But that's not so. About 5% cases in undifferentiated tumors are going to remain unclassifiable, which would not be typed by the immunos. And then the diagnosis, a very reluctant one, but a diagnosis nevertheless, of a poorly differentiated malignant neoplasm would be given. And we should, more the pathologists, less the clinicians, but we should be very conversant with the fact that immunos are not panacea for all ills, and I intend upon there. And we should be obsessive, the pathologists primarily, and the end users, the clinicians after that, about immunoplasticity, about overlaps in immunos, about unexpected absences of immunos, and great crashing where it is unexpected at any extent of imagination. So you would have tumors behaving completely obnoxiously, not expressing what is expected of them, expressing what is not expected of them. And that's where you have to judge whether to go ahead with uninformed, extensive immuno or give a call to the oncologist as to what they are after. I mean, it would be useless to have done a host of immunos and not reach an answer where something in the oncologist's armamentarium was after something very different, but not the tissue type of this cup. It happens. We always should be very well aware that cytokeratin does not always denote a carcinoma. There is a whole host of lesions which express cytokeratin. This image is from, again, one of my own cases. This is a plasma cell neoplasm of the head and neck region, and see how delightfully positive it is for cytokeratins. So if I had done only cytokeratins, I would have easily termed it carcinoma. And with no morphologic clue as to its nature because of its anaplastic nature, I would have ended up with a diagnosis of carcinoma where it is actually a plasmacytic neoplasm. So one should be aware of the situations where only cytokeratin, and when I say cytokeratin, I mean cytokeratin and other epithelial congeners. So they should always be considered that based on the age and the clinical findings in a patient, could we be dealing with something which does appear to be a carcinoma on initial immunos, but it's something else. And adding to the pathologist's woes is the non-specificity of antibodies, loss of immune signals in METs, tumor heterogeneity, and all this is tried to be answered by extending the immunopanels one after the other, having full recognition of the fact that each cycle of immunos evidences a delay of at least 1 to 2 days in the next panel, which is going to be requested. So this is what emphasizes how important it is for a crosstalk always to happen between the pathologist sitting in his ivory tower and the oncologist. I mean, if something can be solved by lesser immunos, it should be the case rather than more immunos and then having nothing for more relevant testing. Having said that, the cup metastasis in more than 50% cases are adenocarcinomas, the so-called adenocarcinomas of unknown primary poorly differentiated carcinomas more than 30%, and squamous carcinomas about 15%. So what is the workflow assessment of coordinate expression of CK7 and 20? We have to start somewhere when dealing with CUP, and when we are sure that we are dealing with a carcinoma and not a lookalike and not an immunomimic, we are reasonably sure that we are dealing with a carcinoma. So how do we go ahead with the workflow? We start with the first step of assessing the coordinate expression of CK7 and 20. I will not let you be worried by the busyness of this slide. Actually, it's easier than it looks. Here it is. So for those cancers which are CK7 positive and do not express CK20, the next follow-up step would be to test for hormone receptors, which separates out two major streams of cancers which can be CK7 positive and CK20 negative. A whole subset of tumors is separated out by their positivity for hormone receptors, namely breast, ovary, and uterus. And those that do not express hormone receptors, ordinarily, I use that term ordinarily because I have seen a lung cancer being positive for about 60% and strong ER. Anyway, so hormone receptor negative cancers are lung, mesothelioma, thyroid, salivary gland, and kidney. For those that express the hormone receptors, in the usual situation, GATA3 positivity would denote breast in most instances, while a GATA3 negative PAX8 positive cancer would, in the usual circumstance, would be ovary. And this would be confirmed and solidified by the positivity of this cancer for WT1. Going from there, GATA3 negative PAX8 positive tumors would be WT1 negative, and then these would be considered as consistent with probably arising from the uterus. Of course, all this would remain conjectural, as clinicians rightly point out, that the last line of the diagnostic category very often reads most consistent with, most supportive of, instead of this is this. That cannot be usually, because we are not sitting there talking with the tumor. That this is why the fact is that because you're GATA3 negative, PAX8 positive, and WT1 negative, you have to be from the uterus. All right, we have an intelligent impression at this level that because of this positivity, the rest of the cancers diminish in importance to be considered over here. Again, we always talk of cross-reactivities and promiscuities. What I always want to emphasize is that situation. Now, again, we have had this case. Unfortunately, I couldn't find visuals from that. Thyroid metastatic to the lung. Now, we all know that TTF1 is positive in both lung and thyroid neoplasms. Thyroglobulin, we usually go to thyroglobulin and say thyroglobulin positive tumors are more likely to be thyroid. A specific type of thyroid cancer, the micropapillary thyroid cancer, can not sometimes express thyroglobulin, and it can express napsin A. So that situation remains the same, that you cannot distinguish based on these immunos, whether it's from the thyroid or primarily to the lung. Here, the PAX8 comes to the rescue, where the thyroid would be expected to be positive for PAX8, while the lung would be negative. Again, coming to WT1, should not be jumping at WT1 positivity looked at the low power, because breast cancers can have cytoplasmic positivity, while true WT1 positivity, which is specific for lineage determination, should be nuclear. So these are finer points which have to be looked at assiduously. The second major category of tumors, which are CK7 negative and CK20 positive. Here, the next discriminatory step is to do endocrine markers. When I say endocrine markers, it's chromogranin and synaptophysin, plus minus CD56. So those tumors which are CDX2 positive and negative for endocrine markers, the major ones among them are colorectal, appendix, bladder, and small bowel. While those tumors which are CDX2 positive or negative and endocrine markers positive, two major tumor types are here, which are Merkel cell carcinoma and salivary gland specific small cell carcinoma. We need to be able to distinguish these sites of origin or resemblance to a putative site of origin for having directed therapies for most of these cancers. And the distinction between Merkel cell cancer and salivary small cell cancer, it hinges upon having availability of the Merkel cell polyoma virus antigen immunostaining, which is discriminatory in this situation. Another possible situation which can trick the Abrari is urachal adenocarcinoma. You cannot be dogmatic for this carcinoma. The CK720 expression profile is not very informative, and one has to proceed beyond that there is possibility of a positive 30-bore beta E12, that's a high molecular weight cytokeratin, which usually would be unexpected in an adenocarcinoma of another type, loss of E-cadherin, and one of the more specific findings, which is the presence of membranous beta-catenin. Usual beta-catenin positivity, which we are trained to evaluate, is nuclear. So if it is membranous, it is very strong, fairly strong evidence that we are dealing with urachal adenocarcinoma, especially if the clinical findings are matching with the pathologic suspicion. The other subset of cancers in which there might or might not be a CK20, CK7 negative profile is the MSIH colorectal cancers. Why I point this out over here is because the immunoprofile is very variable for such cancers. And also, there is the situation where there could be a sporadic MSIH type of tumor. So one should be attempting to see if there are BRAF mutations here, which effectively rules out Lynch syndrome in such carcinomas. Why is it important to confirm colorectal phenotype is, again, as I have said earlier in a slide, that there are directed therapies available. So rather than saying that this is a poorly differentiated adenocarcinoma of which a site cannot be assigned, one needs to strive as much as possible to say where it could be from. The third major category of carcinomas is the CK7 positive, CK20 positive tumors. So this is a rather limited subset, but you would be nervous when you have a tumor which is mucinous in morphology, probably metastatic, as alluded to by the clinician. And then you have this subset of lesions, which could be the tumor you're dealing with. It is problematic because of lack of immunoprofile specificity, and it's here where the team approach and discussion at a consolidated team caring for this patient is recommended, because you could go on doing endless immunos over here and not reach a definite diagnostic opinion as to tissue type or site of origin. Just look at how busy this is. The the fact which I want to emphasize in this slide, it's for the benefit of those who might be attempting short notes if they can remember any of it, that this is about the same cancers: pulmonary, mucinous, pancreatic, GI, ovarian, bladder, etc., especially those with a mucinous phenotype. Just look at those immunoprofiles here. Just look at those slashes, the strokes, where the possible immunomarker can be negative, can be positive, can be positive, can be negative. So nothing is being given over here by immunohistochemistry. At times, you could get lucky in a particular tumor, in a particular case, on a particular day. A proposed antibody for that particular site of origin can come to your rescue, but you should be prepared that possibly the answers will not be coming through immunos. And is the oncologist then looking for something else beyond your attempting 25 odd immunos, if that's possible, and then saying that you have mucinous adenocarcinoma of undetermined origin? The CK7 negative, CK20 negative subset is a rather small subset, not many there, and prostate, liver, kidney, adrenal, germ cell tumor, and the colorectal medullary type of cancers are the ones which one should be thinking of mainly. When I say mainly, there is no absolutism in pathology and none at all in immunoprofiling of tumors. Again, that's just for the benefit of those who might want to go into detail. If you compare this slide from the ones which I projected earlier, the proportion of slashes and strokes have diminished dramatically. So you will see that in this subset, reaching a putative site-specific diagnosis is relatively easier than it is in the other subtypes. Then we come to the complementary tools, which are current today, and most people would want to do something about having something to say about this or to do something about. So let's say that one in parenthesis that we are dealing with a carcinoma of unknown primary, which has a CK7 positive, CK20 negative phenotype, the most frequent type of CUP or adenocarcinoma of unknown origin. So molecular analysis comes into the picture with two primary strategies: ascertaining type stroke tissue of origin. First, the rationale is simple. The more treatment sensitive type of cancers, if they are detected on going beyond immunohistochemistry, might translate into improved survival compared to the other subtypes. There are certain commercially available tests for this, of which the tissue of origin test is the one with the most expansive span of genes being tested, and the one probably, if I am correct, which is the only one which is FDA approved, which claims that it supers immunohistochemistry in a sizable percentage of cases in determining a tumor tissue type or resemblance of the cup to a putative site, which usually would be a primary site if it was not a carcinoma of unknown primary. And the second arm of the strategy is to identify druggable or actionable mutations for which there is directed treatment available. The foundation one in NGS-based assay says that about 85% of cups have alterations which could be used to guide the targeted treatment. And that brings me to the end of this presentation. Thank you.
Thank you, sir. Thank you. I think there's some questions which
Sure.
Dr. Anuj, please go ahead.
Yes. Thank you, Dr. Abrari. As expected, you've delivered an excellent lecture. There are some questions which are coming your way.
Yeah.
The first one is, what's the role of doing IHC? Is it possible to do it on FNAC slides and on cell blocks?
Yeah. We, in fact, if you would remember, we were doing immunos on cell blocks quite frequently back there. And if cell blocks are well made and tissue allowances are adhered to, there's no reason why immunohistochemistry cannot be done on cell blocks. Having said that, expecting the same type of parameters for a cell block determined immunoscore is asking too much. There's no standardization, for instance, for saying what would constitute a acceptable Allred score on some ER staining which you've done on a cell block. I've had a situation where I had 15 cells positive for ER in a background which showed 400 cells, more or less. So this 15 cell group was strongly positive for ER. So if I go by Allred scoring as it is for tissues, I would be giving it a score of something which might not be the reflection of the tumor. I also am not sure where did those 15 cells come from. I mean, are they a subclone, which I would want to believe, or are they merely a contaminant from the control? So then trying to score HER2 on a cell block, then I've been asked to give out a Ki67 index on cell block. So we can do immunos, it's technically possible, but work related to scoring of potential therapy directed scores needs to be done.
Well, I think that the message is clear that it is very much doable on FNA as well as on cell blocks. But when it comes to their significance in biomarker testing, yes, there are some limitations, and the results should be interpreted with caution.
So for this report, in which I was asked the Allred score for this, I said that I see these cells which are ER strongly positive, 15 cells on a background of 400 cells. The final treatment decision lies squarely with the oncologist. Yep. Because the original tumor was triple negative.
Right. So as you mentioned about Ki67, so the next question was, what is the role of Ki67 proliferation when we are dealing with this scenario of cups? How does it come in handy?
Well. Ki67 actually is sometimes it's a reassuring marker that you are at the end of your wits, scratching your head vigorously, sometimes ferociously, and you don't know what to request next. So you request Ki67, that if I have 70% or more here on a background which is inflammatory, again, which would be obscuring Ki67 results, but you have something at the back of your mind which says, all right, these larger cells within that inflammatory background do look malignant. And if they are positive for Ki67, I would be happy in seeing that there is inflammatory cell population present amidst inflammation. And I would say that this is a poorly differentiated malignant tumor and hope for the best. Having said that, in a lighter vein, Ki67 can be helpful. It can be helpful in situations in which you have well-differentiated cups. like which are not so badly gone that you cannot say that these are carcinomas. So you recognize a carcinoma, but you are sometimes in two minds as to whether this tissue has come from something which has been sampled en route at the time of biopsy, or is it actually tumoral tissue? So if the Ki67 in that situation is more than the background tissue, which you would fortunately have sampled there, then you can safely say that you are dealing with neoplastic tissue here and go ahead with the further immunos. And this is very, very important in two situations which I face regularly, is in transbronchial biopsies. Transbronchial biopsies, by definition, sample the native epithelia as well as the, of course, the targeted lesion, and they might resemble each other if the METS is well differentiated, and with all the breakage which occurs when you have a TBLB, you would be hard pressed to actually say that which is tumor tissue and which is not. So if you have both tissues present which resemble each other, and you have Ki7 which is different between these two, then you have a safe playing field there. And I found this very, very exclusively important in small cell carcinomas crushed at the time of biopsy. I cannot distinguish those cells from crushed lymphocytes at times. But crushed lymphocytes would not be expected to have 90% plus Ki67. So that makes it easier for me to interpret. So Ki67 is vital in defined situations. It should not be a blind request all the time. I mean, we should know what we are trying to assess by that Ki67. So there it is for Ki67.
Well, I think you've summed up quite well about the Ki67, because the next question was, what is the cutoff for Ki67?
No, yeah.
I think you made it quite clear that it's a surrogate and a strong marker when in situations when it is quite high, where it helps us to tell that, yes, it's a carcinoma. Definitely we're dealing with a malignancy.
Yeah, you cannot have a defined cutoff for carcinomas as a whole, right? I mean, not all carcinomas can be said to have one Ki67. I mean, cutoff for what? So if it is a high-grade neuroendocrine carcinoma, which I'm considering, and the Ki67 which I'm observing is less than 40%, I would be thinking again whether I'm dealing with a neuroendocrine carcinoma high grade, or is it just a crushed carcinoid? Yeah. So that situation. And in salivary gland tumors, for instance, if I have something which has become, all fragmented during biopsy, and I'm not sure whether I'm dealing with a pleomorphic adenoma or a lookalike, a carcinoma of the salivary gland, and if I have something which goes beyond 20%, Ki67 20% or more, I probably am not dealing with a pleomorphic adenoma. So those situations are to be tailored to the immunoprofile, the clinical situation, the site biopsy, the carcinoma expected, and so on and so forth.
Thank you. I think we are done with the questions which were in the chat box.
So there's one question, which is there a role of IHC in benign lesions? I mean, would there be some time where, because this is something new for me, that would you use IHC to differentiate different types of inflammation, I would say, or probably, yeah. So
yeah. Anuj knows it very well that we would be doing immunos on anything which came under the microscope. I hope the finances are not hearing this, but yeah, well, if you give me a curettage from a possible osteomyelitis, and first of all, you send me a frozen of it and tell me whether it is indeed osteomyelitis, I'll stop in my tracks and say I cannot do that. And then, of course, after I've said that, I'd go ahead even if it looks like lymphocytes, I would go ahead and do immunos there and see for myself that I'm not missing out on a possible leavings there. Having said that, yeah, immunos are used in benign situations, not inflammatory all the time, benign tumors all the time to characterize them. It's very commonplace. Again, I'll come back to salivary glands. Sometimes, especially if people are fond of doing biopsies. I mean, if you have the entire tumor with everything available to assess, you can at times go without immunos. But if you have a needle biopsy from a salivary gland tumor, I would go in with immunos rather than base it on just morphology. Yeah, so I use immunos, and I've been accused of using immunos to a large extent by many people over what is required. But yeah, that's how I practice. Yeah.
All right.
Well,
So, sir, there's this more India-specific question that, because we are very cost-conscious
Yeah,
and we are aware of the cost issues that we have. So,
yeah,
many times, what I gather from your presentation is that the initial panel that we
yeah.
advise. So, should we straight away go for the highest level initial panel, or
No,
we
no, I
start
would
with,
not say
yeah,
that. I
yeah,
would
yeah.
not say that. Now that's very important. I think I touched that point briefly in 2 slides, that once the initial immunos, and with experience, and again, Dr. Anuj would vouch for it, with experience, you would know after having done the initial 1 or 2 panels that this is not moving anywhere. This is the time when you should not be picking up the pen to request more. This is a time when you should be picking up the phone, when you should be talking to the clinician taking care of that patient as to what he's after in that case. After 2 or 3 panels, you can be reasonably sure that this is going nowhere. That happens, and it's easy actually. You can go ahead with doing like this is left, and this is left among the immunos which could have been done. But it's always better for the pathologist after the very initial panels to take the oncologist in confidence and say, see, this is what it is at this juncture, and how are we to go beyond this? Do you need tissue saved or something which you might offer the patient? Is this patient going to benefit at all from saying that this cancer resembles a particular tumor type? Is there any treatment being offered to them based on that? And things like that. I mean, that crosstalk is all important in this situation. It's always important in all aspects of pathology, but it's much more important over here where a repeat biopsy would be sacrilege to ask for.
I think that's very important. Pick up the phone rather than the pen, and that is why it's clinico-radiologico-pathological
Yeah.
correlation, and not just clinico-radiological, and you then leave it on the pathologist to answer some of our.
So actually over here, we do not usually we do not write that this is to be correlated with clinical and radiology findings, because this would be correlated at the multidisciplinary meeting.
Yeah.
So our writing it would be superfluous. And the decision of the multidisciplinary team is at times included in the pathology report to ward off possible, litigation. A decision has been taken collectively with all members of the MDT being present. And this decision is to be going down as a patient's document forever, because this decision is a concordant decision taken with the consent of all present in that meeting. So it becomes part of the patient's medical record. So that at times I would write in my report that because it has come with a request that you have to save tissue for a specific mutation testing. And this is a second biopsy. So beyond saying that there is cancer present in this second biopsy, which resembles the earlier one, I dispense with the immunos the second time, but at the same time, I write it in black and white at the end of the report that due to the specific request for a specific mutation, which might require more tissue, I'm dispensing with the immunos in this situation, as the immunos were done already in the earlier biopsy, and I leave it for the approval of the MDT then. And then when it is approved there that you need not do any more immunos, I usually would include that in my report as well. So yeah, that's about it. That about the crosstalk, it should always be there.
Yes, I completely agree to that. So there's just a couple of more questions, Dr. Anuj.
I think we can take one more question,
Yes,
which says,
please.
okay, so does the site of metastasis impact the ability to identify the primary?
Yeah. I mean, of course, yeah, it does. Limitations, this is more a clinical question, of course. I mean, as a general question, if it is in the brain, like it's a cup in the brain, it's difficult to really say how you are to obtain tissue to do your stuff, to say where it's coming from. So yeah, site would be difficult, as everyone knows. Doing bone biopsies is a difficult thing. So if it is primarily bone, it would be difficult, like bone without a soft tissue component, without cortical breach. It's always difficult to obtain tissue from there. So site is, of course, important in trying to say whether one would be able to diagnose a cup or obtain tissue which is diagnosable. Yeah.
Thank you.
Thank you.
Okay. Thank you, sir. Thank you. That was really nice, and a lot of. So what we do, and I didn't disclose this initially. I should have done this. That, sir, we usually do a video recording of these lectures, and they are there on our YouTube archive, so people can go back, listen to it again at their leisure.
So the evidence is there, recorded and documented.
Yes. Just like you would want a pathology report to be, it's all documented, recorded.
You cannot go back on what you said. Yeah.
Yes. So it's actually we love to go back and really see what we have learned, and we
in
put
fact,
it.
I would like to go back and see what mess I made of something there.
that would be a first, actually. The faculty going back and looking itself. But now we come to the concluding part of it, where I'll request Dr. Anuj to discuss the answers of the 5 questions that we asked, and I'm very sure that all have been very nicely covered by Dr. Abrari. And I'll request Dr. Geeta also to summarize the participation and the quiz.
There is one last question which was put in
please.
by Dr. Nidhi, which says, IHC in brain tumors.
Yeah. So primary brain tumors or secondary brain tumors.
So I think that's the question. If you find an isolated lesion in the brain, and imaging is not, spectra is not helping you, then.
So you give us tissue and we'll do the immuno. We are always willing to do immunos on anything which you give us. So
there is a joke about the brain, no, that you give the whole brain and you still may land up with nothing.
No. You give us tissue, and Anuj can vouch for this. In a brain tumor, which has been which was operated as a possible primary brain tumor, we were able to say that this most likely is coming from kidney, and it was a shocker. And then they went ahead and evaluated the patient, and there was a mass in the kidney, actually.
No. So
this is not uncommon. This is not uncommon. We see it all the time. Whether it is,
The joke was on the surgeons, actually. They took out the brain but missed the primary.
You did do your. So when you say brain, we'll blame the neurosurgeons for it.
Well,
but if it is a non-small cell carcinoma or a small cell carcinoma, then yes, the trigger is on us.
Yeah.
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 I think once the finances are secured, we can do the brainstorming on any brain tumor.
Yes, I agree. I agree. Okay, okay.
Yeah.
So the quiz questions, Dr. Anuj, yes, the answers are
Yes,
highlighted in red.
correct. So the first question was about the co-expression of CK7 and CK20. And now, as already highlighted in Sir's presentation, they are positive in stomach, pancreas, and ovarian mucinous. The only scenario which is unique is a male patient where you know that it is a carcinoma, but it is double. It is not expressing either of them. So we have to think of prostate. The next question. Yes, CDX2 immunostain. Yeah, this is a marker which can come in in many of the adenocarcinomas wherever they are showing intestinal or mucinous differentiation, whether it is colorectal, pancreas, stomach, even lung. So it can be positive in a variety of adenocarcinoma. Yes, so this was on the new marker. So this was a little tricky, I guess. So which is the immunostain which would highly support a colonic origin? Obviously, CK7 is supposed to be negative, and they are CK20 and CDX2 positive in usual scenarios. But the recent marker which if we can, acquire is a SAT-B2, which is positive in colonic adenocarcinomas. So this is about Taxate. It is a very useful marker now being used, generously in almost all carcinomas, and it is positive in kidney tumors, thyroids, ovarian, all Mullerian tumors are Taxate positive except breast. Well, this was a clinical scenario where we have a tumor where clinically it was being thought of RCC or a urothelial carcinoma, but as we see that it was negative for GATA3, so it excluded a urothelial origin, and it was PAX8 negative, which is supposed to be seen in RCCs. Instead, it was positive for enamel and ganretinin, and the diagnosis is an adrenocortical carcinoma. So that was it.
So this was our answer key 4444, and the last one being 3. And Dr. Geeta, your analysis.
Okay, so we've not been doing the quiz for a long time, and then this was purely pathology, but I'm really impressed by the number of participants we had. If you put a total to it, we probably had 50, but at most of the time we had about 40 participants, which is very, very gratifying because most of our talks have been revolving around surgical, radiation, medical oncology, and this was unique in the sense this was purely pathology. So we had a great participation for that. But I think we caught the participants by a bit of a surprise because they were not possibly expecting a quiz. But 5 of them participated, but none of them could get all 5 right. So there was only Dr. Manish got 3 out of the 5 right, which I think is quite impressive considering that this is not that easy a quiz, at least not for us, because for us, everything
we
seemed the
didn't
same.
even attempt it. We didn't even
Yeah,
attempt
because
it.
they were all alphabets put in whichever order they were, so we did not know what they were. But so Dr. Manish, well done, because even a 3 out of 5 is quite.
So which one did most of the people get the 5th one correct? Which one was it that most of the people got?
No, so none of them got the 5th one correct.
Oh,
there was one Dr. Mansi, who gave 2 answers which were both right, but then she did not attend the 3.
okay.
So nobody got the last one right. Nobody except for Dr. Manish. Dr. Manish got it right. He's the only one who got it right. So he got number 1, number 3, and number 5 right. He got the second question and the 4th question wrong.
Okay, great. So, Dr. Geeta, vote of thanks.
Thank you,
Thank you.
Dr. Abrari. Like I said, he never disappoints. So this was amazing. I think we all look at those algorithms to make things easier for us, and I think you did to a large extent. And it's it seems that it was strange, but you are international faculty, and I thank you very much for taking time out for this lecture. And I'm sure we will be inviting you for more in the future. And thank you, Anuj,
Thank you.
for moderating it. And by the time the next
Thanks,
time we invite Anuj, he would also become an international
International.
speaker. So he's also on his way out to the UK. So we will have more August company in the future. Thank you both so much. And of course,
Thank you.
Shubham being the main, spoke in the wheel. So he's the one who really puts all this together. And we are coming up with some very interesting sessions in the near future. One of them being case discussions, which will be held by, which will be conducted by the students. And of course, as part of the jury, we will have you two again on board, because I'm sure there'll be a lot of pathology coming up. Whenever you discuss a case, pathology becomes so important in oncology, at least. So that is where we will be. And Shubham will tell us what exactly we plan to do next week.
So the next week we are continuing with our CUP series, and we'll be talking about the getting a radiation guy to take us through the management of unknown primary in the neck. A proven squamous cell carcinoma. There's no doubt in the diagnosis now after the IHC class. So it's a squamous cell carcinoma with a neck node, and now how do we manage it? How do we plan the radiation? And we'll put in the link. The class is always on Wednesday at 8:30. So we are here with you every Wednesday 8:30. Speaker, we are just finalizing. So that's why the announcement is still pending. So till then, thank you so much. Thank you, Dr. Abrari. Thank you, Dr. Anuj. Thank you, Dr. Geeta, and everybody who joined.
Thank you.
Thank you, and good night. Good night.
All the best.
Good night. Thank
Thank
you.
you.
Good night. Thank you.